Perfect. Thanks, Nelly. So it's quite a big topic, just to put it out there. So let's get going. Um, so autoimmune hepatitis is an immune-mediated inflammatory disease of the liver, characterized by circulating autoantibodies, increased concentrations of IgG, and distinctive histological features. It is a progressive disease that can lead to cirrhosis and liver failure if not treated appropriately. And so it is important to recognize it early and embark on a good treatment strategy. It has been considered quite a rare disease, but there is increasing incidence documented over the last decade in certain countries. And I think it's often perhaps underdiagnosed because people don't always think of it. And so patients who previously may have been diagnosed with a cryptogenic or idiopathic hepatitis may in fact it's always something that over 2 weeks and um, it can new in terms of biology with idea it's multiple patient at immune hepatitis, the HLA genes, non-HLA genes, those have been quite well. It's nice if you're use patient describe also be and picture looks, but essentially the pathogens antigens which differentiate either form increase image and them see great result uh, varied. Normal and then dominant. Our patient becomes more obviously jaundiced, and they then investigated further and found to have autoimmune hepatitis. The other way that patients commonly present is with cirrhosis and complications thereof. So cirrhosis and portal hypertension. So they may come in with a variceal bleed, they suddenly have ascites, some presentation linked to that. So a third of adults are already cirrhotic at presentation, and half of children. And this again just highlights the fact that it can be quite an insidious disease that makes the person feel unwell at times, but without anything specific, and essentially they're having flares continuously in the background and only present cirrhotic. There's a small number of patients who present with fulminant liver failure, sort of closer to 1%. So really by far the minority that present with fulminant liver failure and require urgent transplant. As I said, patients may present as an acute hepatitis, but actually there's quite significant chronicity on their biopsy, and they've presented finally with an acute flare, but they've been having flares for years prior. So it is an autoimmune disease, and because of the genetics associated with it, there are a number of other autoimmune conditions that are associated with this. Thyroid disease is the most common, and then it's important to realize that there are overlap syndromes. So in terms of diagnosis, it's always important to consider in your differential of anyone who presents with a non-specific hepatitis. So it's characterized by generally raised transaminases, and quite high, they can be quite high, up to the thousands, although they don't have to be, they can just be in the hundreds. There's often elevated IgG levels, and the clue on your initial bloods that this might be the case could be quite a high total protein compared to albumin ratio. There are autoantibodies that we test for routinely when trying to make the diagnosis, but there aren't any that are clearly diagnostic. It's always within the clinical context. Histology is extremely helpful in trying to make the diagnosis or confirm the diagnosis, and very useful in trying to elicit how much sort of background inflammation has been going on, just in terms of how much cirrhosis exists or fibrosis there is. And then, as with any patient with a hepatitis, it's always important to exclude other causes or cofactors that may be contributing to the presentation. So just on the right here is it's called the Simplified Diagnostic Criteria for Autoimmune Hepatitis, and it's created by the International Autoimmune Hepatitis Group to try and assist in assist in making the diagnosis. It's by no means complete and perfect. It doesn't exclude autoimmune hepatitis if you have a negative, so to speak, result using these criteria, but it can be helpful. So it looks only at 4 variables, and that includes the autoantibodies. IgG levels, histology, and then the absence of the absence of viral hepatitis, sorry. And a score of more than 6 is considered probable autoimmune, and more than 7 definite autoimmune. We do, however, have a significant number of patients, up to 25% of patients may be autoantibody negative. And so this would definitely underestimate the likelihood of autoimmune hepatitis in those particular patients. This table I've just highlighted and read the things that I think are important here. There are autoimmune hepatitis is divided into type 1 and type 2, and it's not majorly significant, but just to realize that clinically majorly important, but type 2 autoimmune hepatitis, just to highlight, is generally diagnosed in younger people. So it's childhood, teenage years, early adulthood, far more female predominant, as we saw in the initial slide, and generally has a slightly more aggressive disease course. The other thing just to note is that the antibody against the liver kidney microsomal antibody is positive generally, well, if positive, points towards a type 2 autoimmune hepatitis. Whereas if you had a patient who was sort of 60 presenting for the first time, they're almost certainly going to have type 1, and you wouldn't necessarily do the anti-liver kidney antibody because it's not going to be positive in that patient. The autoantibodies that we commonly check for are the anti-nuclear antibody and the anti-smooth muscle antibody. Neither of these are specific only positive in autoimmune hepatitis. I mean, NAs we use in a number of diseases, and we know that you can get false positives. The other thing to just remember is that the anti-smooth muscle antibody can be positive in a number of different liver diseases, and so even something like MAFLD can have anti-smooth muscle antibody positivity, even up to titers of up to 100. So it can be, it's helpful in trying to support your diagnosis, but not diagnostic on its own. The other thing just to highlight here, as I said before, the type 1 usually can occur at any age. Type 2 is usually in the younger teenagers or young adulthood. And as I said, type 2 seems to have quite a significantly more aggressive disease course. And so one is almost certainly going to keep those patients on treatment for life without trying a period of withdrawal. So just in terms of histology really is vital in trying to make the diagnosis or confirming the diagnosis of autoimmune hepatitis. So wherever possible, we would recommend a liver biopsy if you're concerned about autoimmune hepatitis. Obviously, patients who present may be unwell, so you want a patient with a normal INR and hopefully normal or acceptable platelets and no ascites before you do a biopsy. But if a biopsy is possible, it's extraordinarily helpful. So there are fairly typical features which are diagnostic, and we would want 2 out of the 3 typical features on histology, which include interface hepatitis, peripoiesis, and rosetting of hepatocytes, which I'm going to show you examples of now. So this is the lower power view, but it just shows you the dense inflammatory infiltrate, which starts sort of in the interface portal, sort of interface area, and spills out into the lobules. There's, as I said, a dense infiltrate of lymphocytes and plasma cells. So it's important to look for eosinophils because they might push you towards a diagnosis of a sort of a drug-induced autoimmune immunologic DILI, which may also need steroids for treatment, but might just follow a slightly different course. Just in terms of the other features, so as I said, you'd want 2 out of the 3 sort of classic features on biopsy. One is a dense lymphoplasmacytic infiltrate. The other is rosettes, and those are the 2 sort of quite common, or things we see fairly often and things we would want to see in order to make the diagnosis. And then the other classic feature on histology is something called emperipoiesis, and essentially that is another cell. So here you can see a lymphocyte fully in the hepatocyte, not adjacent or surrounding it, but fully inside the hepatocyte. Just on this picture is quite a nice example of a plasma cell, and so lymphocytes are quite easy to see. They're dark, smaller cells, and then plasma cells, which look like this, are quite a nice example of the infiltrate that you're trying to look for. So then just in terms of treatment, we talk about treatment induction and then maintenance. So induction is the aim. So the aim of treatment in general is obviously to induce remission, which would be characterized by normalization of the aminotransferases and ideally the IgG by 6 months. And 2/3 of patients should hopefully achieve full remission if they are treated appropriately and they are compliant. Although we don't routinely rebiopsy patients, normalization of aminotransferases and the IgG, which is essentially termed biochemical remission, is considered to mirror, although it might not be 100%, it mirrors histological remission. And so we don't routinely rebiopsy our patients. So just in terms of induction, steroids are incredible in terms of their ability to treat autoimmune hepatitis. We use prednisone routinely in our practice, and the response of autoimmune hepatitis to steroids is almost universal, so much so that if someone is not responsive to your steroids, one would need to reconsider your diagnosis or check compliance, whether that's the patient taking their pills or whether they are nauseous and vomiting and so not absorbing. But the response to steroids really is quite dramatic. Response can sometimes be relatively rapid, so you see almost an immediate response to the introduction of steroids, but complete remission and normalization of the biochemistry can take quite a while, and even up to 6 months. IgG definitely takes longer than the biochemical tests because the IgG half-life is much longer, and so that you wouldn't want to, that we generally don't test again until about 6 months, whereas obviously the liver function test, which we check quite frequently initially. In terms of dosages of steroids, there's a wide variety of doses that are recommended, and different guidelines recommend doses ranging from 0.5 milligrams per kilogram to 1 milligram per kilogram. In terms of the dose, one just needs to bear in mind that patients are often quite sick. As I said, 1/3 of the adults and 1/2 of children, when they present, are decompensated cirrhotics. And so one needs to balance the risk versus the benefits of starting high dose steroids, particularly where infection can be a significant confounder. So doses of 0.5 milligrams per kilogram don't seem to have any benefit doses of 1 milligram per kilogram don't seem to have any benefit long-term over lower doses of 0.5. Although the biochemistry might normalize a little bit faster at the end of 6 months to a year, the outcomes are fairly similar in terms of time to remission and gaining remission. And so there doesn't seem to be a benefit to using much higher doses of steroids. not even doses of 0.5 milligrams per kilogram can be at the upper limit of what is needed, and patients more often respond to even lower doses. And so one might start, particularly if they're septic or if they have been ill, very ill and decompensated, one can start even as low as 10 and then up titrate to 15, 20, 25, 30 in the ward, slowly under sort of a watchful eye and making sure that they aren't running into problems. Another steroid that is spoken about is budesonide, and I'll mention that again later, but it's not recommended in patients who have cirrhosis. So budesonide is an alternate steroid regimen that has been discussed in the literature. There was some sort of positive feelings towards budesonide because the thought was that there would be fewer side effects, even if a slightly slower response rate. The side effects that were better were essentially turned out to be largely the acne and moon face, which is important, but it's not as significant perhaps of the longer term side effects of bone mineral density, etc. So the starting dose would be 9 milligrams per day. It's not for use in patients who are cirrhotic. But more recently, earlier this year, there seems to be data that it doesn't actually work as well as prednisone and may not be as beneficial as initially thought. And so in our practice, I think prednisone remains an excellent drug for the treatment of autoimmune hepatitis, and is easily available and has a lot of data behind it. Just to note, the patients with acute severe liver failure, in guidelines, again, I have read one or two things about pulsing patients with steroids, but again, there's a very large risk in high dose steroids, and so patients with fulminant liver failure may need to be considered for early transplantation workup. Then going on to maintenance therapy, many of our patients will want to decrease the steroid dose and ideally even get off steroids if possible, although most people seem to need at least a low dose in the background over the long term. In view of that, we try and introduce steroid-sparing agents, and azathioprine is our first line drug. Again, we use much lower doses than are generally used in patients with IBD. So may start at 25 milligrams and go up to 50 to 100 per day. Obviously, azathioprine can't be used in patients who are jaundiced. Their bilirubin needs to be at least below 100 because it alters the metabolism. As I said, we use much lower doses than is often used in IBD, and so the risk of the TPMT gene and the polymorphism associated with it is much less of an issue, and we don't routinely test for that as we don't use the higher doses. Alternative options for patients who can't be on azathioprine, for example, if they are jaundiced, you need to introduce a second agent or steroid-sparing agent, and you're concerned there may be a long cholestatic period. Mycophenolate mofetil is an excellent drug. We usually use up to about 2 grams per day, but again, start low and slowly increase the dose. Very important to remember that MMF is teratogenic, and so particularly when starting in young women, childbearing age, it's vital to discuss contraception with them at the time and to engage in the discussion of pregnancy in the future, and just the fact that they need to not be on MMF anymore. If they choose to fall pregnant, they need to engage with their healthcare provider to ensure a safe pregnancy. And then there are drugs that are discussed as third line options, but essentially if you're requiring these, one has to really go back and interrogate compliance, because as I said, the response of autoimmune hepatitis to steroids is almost universal. Just in terms of prognosis, untreated autoimmune carries quite significant morbidity and mortality and can result in death within 5 years. But the treatment that we have improves the survival. So steroid treatment improves survival, and the addition of AZA to steroids improves the rate of maintenance of remission. Even patients who present very unwell with significant fibrosis and even cirrhosis at the time of first presentation may respond well to steroids, and they have a survival benefit from being treated. Liver transplant is something that we would consider in those with fulminant acute failure, severe decompensated cirrhosis, or those who have developed HCC on the background of their cirrhosis. Patients have a good survival of more than 80% at 5 years, but there is a significant risk of the recurrence of the autoimmune hepatitis within the transplanted graft liver. And so that can be as high as 8 to 12% within a year and up to 68% at 5 years. These patients are obviously on immune suppression following their transplant, but they are being transplanted for a very immunogenic disease. Just a quick note on withdrawal of treatment. So to stop or not to stop, essentially. Again, in guidelines, there's some discussion about withdrawing treatment to see if patients can maintain their remission off treatment. Before one considers that, patients should be in remission for at least 2 years with a normal IgG and normal liver function tests, and they need to have been on treatment for a minimum of 3 years. So earlier I did say that we don't generally repeat biopsies to prove histological remission if we have good evidence of biochemical remission. But if you were to consider withdrawing treatment or trying to stop treatment in a patient, one would need to repeat the biopsy to prove that there is complete remission histologically as well. Relapse is very common, and so I think it's important to remember that when you diagnose someone with autoimmune hepatitis, it's important to counsel them that this is almost certainly a lifelong disease. Well, it is a lifelong disease and a disease that's going to need lifelong treatment. Relapse after the withdrawal of treatment is very common. It usually happens within the first year, and anyone who has ever had treatment withdrawal and relapsed is never qualifies for a trial of treatment withdrawal again because of the risk of severe flares. Patients who do maintain remission once treatment is removed will need lifelong surveillance because they really can flare at any point and may need to start treatment. And so even those one is able to withdraw treatment are never sort of discharged from the system. They still need lifelong monitoring. Just general supportive care for these patients as well. They need malignancy screening, as many of our patients do. Those who are cirrhotic need HCC screening 6 monthly with alpha-fetoproteins and ideally ultrasound. And then those on azathioprine have a much higher risk of non-melanoma skin cancer. So they need advice on UV protection and may need referral to dermatology for suspicious lesions early. Bone protection remains a concern due to the long-term use of steroids. Patients need DEXA scans, regular routine calcium and vitamin D supplementation, and may need bisphosphonates. And then vaccination, as with all our patients on immune suppression. A note just about autoimmune disease, autoimmune hepatitis in pregnancy. Autoimmune hepatitis is not a contraindication to pregnancy, and many of our patients, this is a scenario that is entirely realistic because there are there are a large number of patients who are of childbearing age. But before they fall pregnant, we would like them to be in remission and well established on treatment. The biggest predictor of outcome and complications in a pregnancy in a patient with autoimmune hepatitis is how well their autoimmune hepatitis is controlled. And so if they have flares or if they are not in remission, there's a much higher risk of both fetal and maternal complications. Both prednisone and azathioprine are safe in pregnancy, and as I mentioned, MMF is contraindicated because it has got significant teratogenicity. Patients who are on MMF and wish to fall pregnant and would not be candidates for azathioprine can be managed on steroid monotherapy for their pregnancy. They need to be monitored more closely during their pregnancy as they may flare. And this continues post-delivery as well. So patients may do fine without increasing their medication during their pregnancy, but post-delivery may flare quite significantly and need higher doses of steroids for a short time. We don't empirically increase their steroid doses, but they do need to be followed up very closely. So 2 weeks post-delivery, and if they're doing all right, maybe monthly for 3 to 6 months, depending on how they do. Okay, so that's autoimmune hepatitis in a very small nutshell.
So thanks, Liz. If I may interrupt just to give you a breather and maybe perhaps you have a moment to sip a glass of water. So thanks again. And for those who sort of joined us a little late, I am, sorry, let me just show my video. I am Nelly Swakogela. I'm one of the hepatologists at Cape Town. We've just given you a sort of tour de France about autoimmune hepatitis. It's a massive topic, and Liz did a wonderful job just trying to summarize it in few slides within 30 minutes. It's rare, but still remains underdiagnosed because the index of suspicion for it is still very, very low in the general population amongst us as doctors. It is always should be a consideration when you see a patient with a transaminitis where you have excluded viruses. Liz has highlighted that it affects mostly females and can affect all age group, but it should be a possibility even in patients who are beyond 60 because it has a bimodal age pattern. Often liver disease, as we know, they are asymptomatic, but fatigue should ring bells, and therefore one should be screened with liver function tests. In teenagers or early adults, not uncommon to see them presenting with intractable acne, or young ladies presenting with massive stria, looking as though they've had a couple of pregnancies. So those certain clues might help you make that diagnosis. Clues, again, is your transaminases, and it's also important to note that about 20% of these patients might be autoantibody negative. Therefore, that can throw some people off or can make people kind of consider autoimmune hepatitis less likely. There was a question on the chat which I tried to answer very briefly, where I think it's a fellow possibly asked, is a liver biopsy mandatory? It provides one with valuable information. It's a gold standard for diagnosing autoimmune hepatitis, as Liz has kind of described the patterns that you see where you've got heavy portal tract inflammation composed of lymphocytes and plasma cells. Classic, you see this rosette formation. And again, liver biopsy, we know to provide you with information with regards to the amount of scarring that the patient has endured as a result of late diagnosis or you know, as a result of repeated injuries from flare. The second question was about the steroids. If steroids are for long-term use, ideally you want to try and get them to as little or as no prednisone as possible. Again, as Liz explained, that steroids are used mainly for inducing remission. So it's your first line therapy to try dampen that inflammation very quickly, but we do so very gently, because patients with liver disease are very fragile and therefore prone to infection. So if you whack them with high dose of prednisone, you might push them over the edge and you might not be able to get them back. So what we usually do when patients come in with autoimmune hepatitis, we start slow, we build up, and max really we end up giving them is about 30 milligrams. So we're more on the side of 0.5 milligrams per kilo. And when cholestasis is settled and the patients are feeling better and less nauseous, and then we slowly introduce our steroid sparing agent, in this case, your azathioprine. And usually patients tolerate up to 100 milligrams of AZA. And when they are stable in that and the LFTs have normalized, roughly we wait for about 3 months and we slowly reduce the dose of prednisone, monitoring closely those transaminases and your IgG. And, very infrequently we stop prednisone, but I think most of our patients end up just being on 5 milligrams. And those are your model patients that are really compliant. The question that I sort of left was, again, sorry, to the histology question. We know that obviously depending on whether they present with liver failure, as in they've got coagulopathy or they've got platelets or they've decompensated, then those patients, you can't really biopsy them. So if you can biopsy, by all means do so. It's got valuable information. I think I went to town talking about the steroids. And then the one question that I said we can discuss, I'm sure we've got very senior clinicians in the audience. I think I saw Wendy coming through. We know that autoimmune disease, they run in families. And obviously patients with first degree relatives who've got autoimmune liver or any other autoimmune conditions, they are at risk of having autoimmune hepatitis, but we don't really routinely screen patients because they report that they've got families who have autoimmune hepatitis. FibroScan, we know FibroScan has got a role in monitoring patients with chronic or advanced liver disease. Its usefulness is to sort of, while you're managing and controlling the inflammation, you hope that with time the liver will get better and the scarring will improve. So it's an ideal tool to monitor the progression or rather the regression of that fibrosis. Again, that's provided the patient does not have ascites or other contraindications to interpreting FibroScan results accurately. And the last question from Sandy, given the fact that patients can present already in cirrhotic stage, are there histological patterns that can point towards AIH-induced cirrhosis? Example, large nodules, small nodules, mixed? Yes, so patients presenting in advanced stages as in decompensated cirrhosis, again, you can't biopsy them because of coagulopathy, as we know that autoimmune hepatitis is associated with quite marked synthetic dysfunction. Also, if they've got ascites, some brave individuals might, say, listen, you can go transjugular, but is it worth the risk? If it quacks like autoimmune hepatitis, as in small shrunken liver, ANA is positive in your typical individual, I'll suggest you manage as that. Also, when they're cirrhotic, that liver is very small, so it's very dangerous to actually try and force the liver biopsy in that setting. So again, you need a high index of suspicion and you need a good clinical argument to sort of say this is likely autoimmune hepatitis. I mean, I remember early in my training, we had a young lady who presented with a massive liver from regenerative nodules. In fact, we thought it was we thought it was hepatocellular carcinoma, and it turned out to be quite an impressive flare and regenerative nodules from autoimmune hepatitis. And that information, again, we got from histology, from a dismal or, poor prognostic possible clinical scenario to a condition that we could manage with just steroids and gentle supportive therapy. We managed to give a few years. If there's anyone who wants to, Wendy, I see has raised her hand. Wendy, you can unmute yourself and let's see if I can. Yeah.
Hi, everyone.
Hi, Prof.
Hi. Excellent presentation. So just in terms of that question that you've just answered in terms of macronodules, micronodules, I mean, that case that you recalled had repeated flares of autoimmune hepatitis and massive regeneration. And what can often happen then is that they get almost a pseudo-Budd-Chiari. So those massive regenerative nodules compress the IVC. So on imaging, it often is mistaken for Budd-Chiari. And that can be quite problematic in managing those patients. The other important thing in patients presenting with decompensated cirrhosis, so they've got ascites and encephalopathic, and often sepsis is tips things over. You get them through that, and what you will find often whilst they're very sick, that the transaminases are in double digits. And in fact, they don't need any steroid therapy. And so even though you've diagnosed autoimmune hepatitis, it's important not to actually start these individuals on steroids. And then as you follow them up and they start getting better, you see those transaminases beginning to rise. And that's a situation that you'd come in maybe just with 10 milligrams of prednisone. And I think just the other thing, the IgG has been very useful, particularly in our patients with seronegative autoantibodies. But one of the problems is sort of over the age of 60, they don't seem to mount a very high IgG response as well. So it can be not as easy to make that diagnosis. Thanks.
Thanks. Thank you so much. Very, very, very important point, Prof. As these patients always steady does the trick, and not rushing in with therapy, especially when it's not going to change much, is very important. And like I said, if you do something quite dramatic, you might push them over the edge and you might not be able to get them back. We've got two more topics to cover, and I think I'll hand over to Liz to continue with the rest of her talk, please.
Alrighty, so the next two things that I'm going to speak about is primary biliary cholangitis, so which I will call PBC, and then primary sclerosing cholangitis, which I'll call PSC. So PBC is a chronic progressive autoimmune disease again, which results in the destruction of small intrahepatic bile ducts. It leads to cholestasis, inflammation, and ultimately cirrhosis. The hallmark feature of these patients is that almost more than 90% of them are anti-mitochondrial antibody positive. And this is just the typical patient is an older white lady, is essentially the picture of the person who gets PBC. So it is a rare disease, significant female predominance, so 9 or 10 to 1, and mainly people over 40 years of age. Okay, pathogenesis, this is too complicated. Essentially, it is a genetically susceptible host with certain environmental triggers which result in a T cell mediated attack on the biliary epithelial cells in the intrahepatic bile ducts. This results in cholestasis and then ongoing inflammation. So in terms of presentation, the patients present profoundly fatigued and with significant pruritus. And these are often the most common and major symptoms that people complain of. Fatigue and pruritus can be very significant, but are not, and can be there independent of disease stage. And so just because someone is very fatigued or has significant pruritus doesn't mean they have very severe disease necessarily. Patients may also present jaundice. There's a strong association with Sicca syndrome, so dry eyes, dry mouth, metabolic bone disease, and then hyperlipidemia. If you saw in the initial picture, the patient with these sort of xanthelasma can be a significant presentation. Can be found as an incidental finding in patients with abnormal LFTs that are then further investigated. And although it says the sort of stats I read were about 50 to 60%, I think a lot of those patients have often gone seeking healthcare just for and complaining of fatigue, and so they're not truly asymptomatic. And then that begins the workup. Again, patients can present cirrhotic with portal hypertension and all the associated complications thereof. So there, as with autoimmune hepatitis, it is an autoimmune disorder that is associated with other autoimmune disorders. Sjogren's syndrome, thyroid disease, and IBD are significant associations. So the diagnosis you need to consider in the correct clinical context. Essentially, it's often an older lady with Caucasian heritage who has pruritus and fatigue. There may or may not be jaundice. It's important to exclude extrahepatic biliary obstruction. And then one needs 2 out of these 3 criteria to sort of clinch the diagnosis. So ALP and or GGT, which are raised. ALP is often raised in PBC. An antimitochondrial antibody that is positive with a titer of greater than 40. And then histology, which is suggestive of PBC. We don't often biopsy these patients because most of them present with as I said, more than 90% of these patients will have an AMA that's positive and a raised ALP. And so histology is not often needed in the diagnosis of these patients. Interestingly, the antimitochondrial antibody is against the M2 component of the pyruvate dehydrogenase in the inner membrane of the mitochondria, and is highly specific for the disease, but is not actually in itself pathogenic. Just in terms of the histology, one would see florid duct lesions with the lymphocytic infiltrate, and often you find granuloma formation, and that's what can give you the clue when you're looking at the biopsy. In terms of management, essentially management is guided by the stage of disease. Patients who are diagnosed early can be managed very well and have excellent outcomes. Those who are diagnosed when they are already cirrhotic, I said here conservative treatment. What I mean is medical treatment, not, once they're decompensated, cirrhotic, or having multiple complications, they often need to be worked up for transplant. So fibrosis without cirrhosis can still be managed medically, and one needs to see what their response is to treatment. But those who are decompensated, cirrhotic, and have multiple complications essentially need to start being worked up for transplant. Just a note that there is an entity of called AMA negative PBC, obviously not as common, but it has a similar course and prognosis and behavior as AMA positive PBC. So the cornerstone of management for these patients is ursodeoxycholic acid. It has an incredibly beneficial effect. It is used as a dose of 13 to 15 milligrams per kilogram per day, and not in higher doses. It improves liver chemistry, delays progression, and prolongs transplant-free survival. There were studies done looking at higher doses, so closer to 28 to 30 milligrams per kilogram, but they had to stop that early because there were deaths. And so it's crucial to remember that we don't use high doses of urso. We maintain this dose of about 13 to 15 milligrams per kilogram. When treating people with PBC, first-line treatment, as I said, is urso, and it's important in terms of risk stratifying them to assess the response to treatment after 6 to 12 months. There are multiple different scoring systems which one can use in order to assess the response, but essentially we're looking for normalization of the ALP and total bilirubin. So 30 to 50% of patients may have an incomplete response to urso. All patients, however, do show benefit. And so all patients who are diagnosed with PBC need to be put onto URSO provided that they tolerate it. And then the decision is then just whether you add a second agent or not. For those who are diagnosed early before they have significant jaundice, cirrhosis or fibrosis, their survival may approximate the unaffected population, particularly if they show good response to URSO, and so it remains the backbone of treatment. This graph I found really useful, just showing patients diagnosed with PBC. And in this first graph, one can see those started on URSO who then had a good response to URSO, and essentially long-term, their outcomes were similar to the standardized population. For those who had an incomplete response, one can see that their outcomes are worse than the standardized population, but of note, their outcomes are still better than those that are untreated with ursodeoxycholic acid. So it remains a very important part of treatment. I won't spend too long on this. Obeticholic acid has good evidence that it is effective as an add-on treatment. In 2016, there was a trial published in NAGM which showed a significant improvement of those who were incomplete responders to URSO who had obeticholic acid added. They had a significant improvement compared to placebo. We unfortunately don't have this available in South Africa, but just to be aware that it is recommended in those who are poor, who are incomplete responders, or can be used as monotherapy in those who are intolerant of URSO. It's just important to note that it is contraindicated if you have decompensated cirrhosis and portal hypertension. And there was a note that it may increase pruritus, which is a major problem for many of these patients. What we do have available is as an add-on treatment of fibrates. They have also been well studied and show significant benefit. They improve biochemistry in terms of the ALP and bilirubin, and they actually may help improve the pruritus. And so that's definitely a positive in terms of these drugs. Again, there's limited evidence of how these drugs would fare in advanced liver disease. And so again, the goal with PBC really is to diagnose it early and treat it early before one reaches significant fibrosis and cirrhosis, because outcomes really are very good then. Fibrates can also be used as part of essential triple therapy in places where obeticholic acid is available in those particularly difficult to treat patients. This is from the EASL guidelines, and I just wanted to put it in here as a reference if you look through slides later. But essentially the sort of 3 pillars of managing PBC are: one, to make the diagnosis and then risk stratify the patients, and essentially risk stratifying them is evaluating their response to ursodeoxycholic acid. Those who respond well need to continue on that lifelong, and they have very good outcomes. Those who have inadequate response, ensure that there are no other cofactors that need treatment and consider add-on therapy. One needs to stage your patients initially. It will help provide information on what the likely prognosis is, but also if they're cirrhotic, it points towards various screening and add-on therapy that may be needed. And then just to remember, they have significant other symptoms, particularly pruritus and fatigue, as well as vitamin deficiencies, bone density issues, and so that those issues need to be actively managed. In terms of monitoring of these patients, we essentially are looking largely at the bilirubin and ALP, obviously looking at the full liver function tests. If they have high transaminases, one needs to consider an overlap syndrome, and it's in those patients where biopsies are sometimes useful if you're concerned about PBC autoimmune overlap. Liver stiffness measured with transient elastography can be very helpful in staging your patient. And then those who are confirmed to have cirrhosis need normal HCC monitoring and endoscopy for varices. Again, good holistic management with bone, metabolic bone disease and vitamin deficiency supplementation. In terms of transplants, there are a decreasing number of patients with PBC being listed for transplant, and I think this is essentially secondary to the confirmation of URSO as an excellent treatment choice, and trying to diagnose patients early and starting them on URSO early. Patients who need to be considered for transplant are those whose MELD score reaches 15 or more, or those who have significant complications of their cirrhosis. In terms of transplant outcomes, 80 to 85% of patients are alive at 5 years post-transplant. The concern is the recurrence of about 15 to 20% at 5 years. It's important that these patients be put onto URSO immediately post-transplant to ensure that they don't, to try and prevent any progression of the disease. One would need a biopsy to prove recurrence. Just in terms of pruritus, I won't go through all of this. The pharmacological and non-pharmacological management, this is one of the most frustrating features for people, and so it's important to manage. Right, PBC, we're almost there. PSC is another chronic cholestatic liver disease. The important thing about this is it's characterized by damage to the larger bile ducts, both intra and extrahepatic. You had multifocal bile duct damage and strictures, and there's a frequent association with IBD. It's always important in making this diagnosis to exclude any secondary causes of sclerosing cholangitis. It's a more male predominant disease, and the peak incidence is slightly younger than with PBC, sort of 20 to 45. In Africa, there's very little data, and it's one of the top reasons for liver transplant in South Africa. Pathophysiology, again, is a genetically susceptible host with environmental triggers, immune activation, and damage to the biliary, to the bile ducts. Subtypes of PSC, so you get classic or large duct PSC, and that has by far the most common typical features are diagnosed on MRCP. Small duct PSC, about 10%, and that is often needs a biopsy to make the diagnosis. And then there's pediatric PSC. Many patients may present asymptomatically. One has IBD patients who follow up and notice that their ALP is slowly rising, and they are therefore investigated for PSC. Otherwise, if they present with their PSC primarily, they may present with jaundice, right upper quadrant pain and cholangitis, as well as with fatigue, pruritus, and loss of weight. MRCP is diagnostic in large duct PSC, which is 90% of the cases. Biochemistry is fairly typical for biliary disease in that the ALP and GGT are raised. If the transaminases are significantly raised, one may need to consider autoimmune hepatitis overlap. There are no specific autoantibodies, although there are many that may be positive. Biopsy, as I said, is needed to diagnose small duct PSC. So in a patient with a history that's highly compatible, but MRCP that's not diagnostic, one might consider a biopsy, or in those where you consider overlap. FibroScan can be useful in staging these patients. So MRCP, highly sensitive and specific. You get the classic sort of beaded appearance where you get alternating strictures and then areas of dilatation. On biopsy, one can see these typical onion skinning lesions around bile ducts. But like I said, that's mostly in specific clinical scenarios where one would consider biopsy. Strong association with IBD, so 70 to 80% of those with PSC will have IBD. and so all will need a screening colonoscopy. Ulcerative colitis is the most common. It can be very mild disease. It can be more right-sided with backwash ileitis. In doing the colonoscopy, they need, even if it looks macroscopically normal, patients will need multiple biopsies throughout the colon in order to diagnose or exclude the presence of IBD. Those who have associated Crohn's is usually Crohn's colitis. And just to bear in mind that IBD can appear at any point during the disease course and may even only appear after a patient is transplanted for their PSC. There's a high risk of colorectal cancer in those with PSC UC overlap, and so they need annual surveillance with a full colonoscopy. Just in terms of treatment, there's no proven effective medical treatment. Many have been trialed, but none have proven to prolong transplant-free survival. Urso, again, is used in many patients, again at a lower dose of 13 to 15 milligrams per kilogram. It's important one can trial this, provided the person doesn't have a dominant stricture. And if there's no response or no change, one can consider stopping. Transplant is the only modality that is proven to prolong survival, and someone who has developed jaundice with a total BILI of more than 100, not associated with a new dominant stricture or infection, should be a trigger to consider workup for transplant. PSC recurrence in the transplant is about 35% at 5 years post. Okay, can essentially transplant-free survival. There's a dramatic 50% of people have either died or need a transplant after about 13 years. So complications, I promise we're nearly at the end, include recurrence in the transplanted liver, cirrhosis and portal hypertension with all those complications, recurrent cholangitis, and fat-soluble vitamin deficiencies. Overwhelmingly, these patients are at high risk of malignancy and need very aggressive screening and monitoring for that. 40% of the mortality in PSC is associated with malignancies, and those are hepatobiliary and colorectal largely. So just in terms of screening for cholangio, there's an increased risk with older age and male patients. There's a higher risk within the first year post-diagnosis, and the appearance of a new dominant stricture should raise the concern of a cholangio. Less than 25% of those strictures will turn out to be a malignant cholangiocarcinoma, but they all need to be investigated. Ideally, annual imaging with MRCP is recommended, but that's not really practical. And so ultrasound and serum CA19-9 are often used. The serum CA19-9 can be raised with many conditions and go up and down quite a lot with infection, etc. And so it's not a great screening tool. Gallbladder carcinoma, much higher risk in these patients. And so anyone with a polyp or lesion within the gallbladder needs to have a cholecystectomy. Hepatocellular carcinoma, again, traditional screening practice of alpha-fetoprotein and ultrasound, ideally 6 monthly, but annually if can't. And then colorectal cancer, as I said, is a very 10 times increased risk in these patients. And so anyone with PSC and UC needs annual colonoscopies with 4-quadrant biopsies. And yeah, we're almost at the end. So this is just a summary of the PBC versus PSC, just to highlight the female predominance in the one, male in the other, the antibodies that are very specific in PBC, and the site of involvement. I think we're at the end. Okay.
Thanks, Liz. I mean, impressive. Truly, to squeeze every ounce of information out of these 3 autoimmune liver disease in 1 hour is commendable. And thanks to everyone who stayed true till the very exciting end. So basically, patients presenting with abnormal liver disease, your diagnosis is not complete or your differential is not complete, you haven't considered autoimmune liver disease. Patients with cholestatic pattern, please consider these 2 diagnoses. And as Liz has outlined, they're fairly straightforward to diagnose. And just in closing, just please, remember this happens every 2 weeks. But firstly, I'd like to thank Liz, and I'd like to thank all the people that participated in this discussion. I'd like to thank the ECHO University of New Mexico and ECHO India team for the support. Please note that this presentation will be available on the Gastro Foundation website, so you can go through it at your own leisure and indulge on this wealth of information. The next presentation will be on the 27th of March this year, and the topic will be a metabolic associated fatty liver disease, and Dr. Sandy Musenye with Professor Wendy Spearman will be leading that discussion. I'm quite 100% sure that you will enjoy it. So please join us in the next 2 weeks where you will be hearing all about metabolic associated fatty liver disease. Thank you, everyone. And thanks, Karen, for inviting us to come and chat about autoimmune liver diseases. Thank you.